9 years. It takes 9 years for a woman in the UK to be diagnosed with endometriosis. 9 years. But she doesn't get diagnosed while she's in her 20s. She gets diagnosed when she's in her mid-30s to even late 30s. 9 years of gaslighting. 9 years of saying, it's only a period pain. 9 years of crying in the bathroom. 9 years of not being able to reach that promotion because she's had too many sick days. 9 years of not being heard. And that's what I see day in and day out. And by the way, if you look like me, or if you're a woman of color, it's not about the time. You might never get diagnosed. And this is the reality of gaslighting in women's health. There's not enough conversations, and this is also minimized. That it's just a woman's problem. Every woman has a period. What's wrong with her having the period? And what's wrong? It's every woman goes through it. Why are you in so much pain? I'm Shanila Chowdhury, and I am the founder of Holistic Pink Ups. I myself went through 1, 2, 3, but 5 devastating miscarriages. Bad luck, I was told. So I decided to do something. I decided to become the therapist I couldn't find. Because I had a choice. Do I become a mother yearning for a child? Or do I become that therapist that can help women have children? And now I'm proud to say I have helped hundreds, if not thousands, of women get pregnant naturally and successfully. But I can go on, but this panel is not just for me. And I have 2 esteemed guests with me. And I want to start, because we've decided to do it a little bit different. You see, you can do the speech, but you never remember the questions. I'm going to start with Dr. Vindhya. I would like her to introduce herself, if that's okay. But I've also got a question that you can answer as well.
Yeah, first, let me introduce myself. It's a privilege to be here with such a change makers. So let me introduce. I'm Dr. Vindhya Gemaraju. I'm a senior obstetrician, gynecologist, laparoscopic surgeon based in Hyderabad, India. I'm a founder of SO Health Corporation. I specialize in very advanced gynec surgeries, which we call it as a V-node surgeries, which is a scar-free surgery where we operate through vagina, where there won't be any pain and no scars. Along with that, I do a unique 360-degree integrative women wellness model where we focus mostly on the preventive and restoration of the woman's health. So my journey into the women's health has started a decade back when I heard the woman repeatedly saying that why I had not been heard before. This changed my thinking as a clinician. As a clinician, I see many women suffering with PCOS, endometriosis, adenomyosis, and fibroids, and chronic pelvic pain. When they are able to diagnose through investigations, they had been treatment. But when they are not able to diagnose, they used to be heard about that saying that this pain is not there and this is not real real pain, and this pain is in your brain, and this is normal, as Shanila said, and it is normal for women. So this led to the misdiagnosis or sometimes delayed diagnosis, delayed treatments, and there will be misdiagnosis along with the unnecessary use of lot of medications and surgeries. So overall these years I understood not being a good surgeon is enough. I need to be a good listener, and I need to educate the patients and women, and I need to help them to heal in their process. So overall these years I developed a women care plan where I have combined the things, like as a doctor I know what all the things which is the scientific evidence based medications, surgeries, along with the natural wellness protocol where I combined the physical fitness with the mental well-being. I added the yoga, I have added the nutrition and the herbal infusions which are therapeutic, so to help the women in their pain. So today I am here not as a doctor, as a voice for the woman who has been said that pain is not real, it is there only in your brain. So with a clear-cut care pathways, we can help them heal not only physically, emotionally, but through their lifestyle changes. As an obstetrician and gynecologist, I am compassionate about the woman's health, and I have a clarity how to do it, and have a courage to say no to the procedures which are truly not required. Thank you.
I would request Dr. Deepak to give his introduction, if that's okay.
Absolutely. Thank you, Shanila, so much there. So good morning to all of you. It's been a wonderful day yesterday, and really honored to be part of this panel this morning. So my name is Professor Deepak Ravindran. I'm a consultant within the National Health Service and a specialist in lifestyle medicine and pain medicine, originally trained in India, but now working for the past 2 decades in the United Kingdom. Essentially, my clinical work and my academic work spans this breadth of pain, chronic pain, lifestyle medicine, focusing on long-term conditions, especially in women with regards to pelvic pain, autoimmune conditions, long COVID dysautonomia. And what I've realized is this topic today, women's pain that we talk about, the concept of medical gaslighting, the concept of misdiagnosis, delayed diagnosis, something that was mentioned in the previous panel. This is a structural and a systemic problem globally that we need to address more urgently. There's a lot of changes there. And so actually, in some ways, my key mission through my center is been to talk about raising awareness, talking about trauma-informed care, talking about lifestyle medicine-based practices, awareness of social determinants of health, and my work in clinical practice is involving bringing all of that together to give a more integrative approach to my patients in my service. So I'm really honored to be part of this conversation today and to have that sort of ethical innovation that we're going to speak about and that cultural humility that we need to have when we address something such as women's pain. Thank you.
I'm intrigued, Dr. Vidya. In the healthcare system, where women's pain is often dismissed or over-medicated, how does your surgical innovation like V-Notes and your 360-degree integrative model offer not just better outcomes, but a radical shift on how women are seen, heard, and healed?
Thank you for your question. This is an important and powerful question. So the pain in women is dismissed. It's not it is not obvious, but it is a subtle, because we see this dismissal of pain in a rapid prescriptions and lack of clarity and lack of patients to listen to the patients. So in my clinical practice, I have started doing in 2 ways. So I have 2 tools. One is the 360-degree UniQ model, where I will personally sit to the patient, talk to the patient, and I have a team of people who will cooperate with me, like physiotherapist, I have psychiatrist, I have nutritional therapist, yoga therapist. All these people will sit together. So first what we will do is we will sit with the patient, talk to the patient. So every patient may not be able to open up in a single visit. So we'll ask them to come to us after 2nd visit or 3rd visit, depending upon that and how they open to us. So once they open to us, we try to talk to them clearly what is their problem. Not every problem is physical. Sometimes it may be there mentally also or emotionally also. So we try to talk to them, and after that we sit and write a pro forma for them, and we give a pro forma to the patients and women depending upon their disease or on their problem. So in that we will ask them about their lifestyle, how much sleep they have, how much sedentary lifestyle they have, what is the nutritional status, and what all the dietary habits they have, and what all the conditions, preconditions like thyroid they have, anything like hypertension, diabetes, and we assess the physically like their weight, height, waist to hip ratio, everything. We assess physically, and sleep and stress levels, everything will give a pro forma to them. We will ask them to rate that, whether the stress is 8 according to the scale. We ask them to rate either they have a stress level of 8, 10, or how is her sleep levels. All those things we'll try to ask them, and we will ask them to write it down on a pro forma. After that, we will prepare a personalized and tailored protocols for every woman who are suffering with the certain type of diseases. So in that, we give you some exercises, therapeutic herbal infusions depending upon their problems, and we will do the yoga, and we always do these exercises 5 days a week, and we'll give a break so their muscle get their relaxation time. So we ask them to we ask and encourage them to do these things for at least 3 months with us, so that they will have a definite protocol how to do it. Because many patients I have seen saying that, okay madam, we are doing it, but we are not able to come to there. So we will help them how to do it and how to daily plan accordingly. We'll help with them. And not only for the women who are in the adolescence age group, reproductive age group, who are trying to plan pregnancy, who are not feeling well, especially in the menopausal and perimenopausal, because of their hormones are getting down. So all stages of women, we will try to prepare a protocol for them so that their life will be happy and healthy. If this is not working for them, and after trying all these natural ways, still they are not able to get relief of these problems, then my surgical intervention will come. This surgical intervention which we do, we call it as an VNOTS, which is a vaginal natural orifice transluminal endoscopic surgery. This means we operate through vagina where there will be no cut and pain will be free. Many women fear of pain and lack of time because of their professional works and their personal commitments. So they fear of getting their surgeries done very fastly. So they get delayed for the surgeries also. So their problem will get more and more aggravated. With this newer innovation, which is very beneficial for the patients because the recovery time will be very fast. When we do surgery, we will discharge the patient within 24 hours after the surgery, and we will ask the patient can resume their works within 7 days. So this is very fast recovery will be there. And psychologically also, if the patient does not have any cut on their tummy or on the vagina, they will feel more relaxed that the surgery was not done that way. So they feel more relaxed and they get up to their more work even in emotionally. So these two models will help me to treat the women problems, and this will help us to treating with dignity. And whenever we stop medical gaslighting, when we start listening to the patients, we have seen many women getting treated without pills. This is more important because the most important thing they want us is to participate in hearing their problems and helping them in healing. So what my most thing is not the outcomes, but we need to prepare a care plan where the woman is respected, listened, and empowered. So I thought healing does not start in the operating rooms or in the medications. It starts with listening to the patients. Thank you.
Thank you. That's very, very thorough, and it sounds as if the women are seen and heard and healed. So thank you. Dr. Deepak, as someone who specializes in pain and lifestyle medicine, what patterns do you see in how women's chronic pain is often misread and mismanaged? And what frameworks do you suggest for making pain care more inclusive and truly trauma-informed?
Thank you, Shanila. I think this is something that both of you have already touched on in some ways. In the UK last year, 2024, there was a Women's and Inequalities Committee parliamentary inquiry. And the quote that you gave from there, 9 years, this is the time that it takes on average for a woman's pain to be properly diagnosed, to be heard, and to be validated. And I think a lot of it comes because we are still being taught in healthcare schools to view pain from a very biomedical lens, from a lens that is exclusively focused on saying that the cause of every pain would be found by looking at some form of imaging, some form of scan, or something on a blood test, if not on a laparoscope. And I think Vindhya and I would be the first person to actually say, anybody in the audience here, do you have an idea of what is the rate of positive diagnosis when you have a look through a laparoscope for a woman's pelvic pain? Any numbers? I'll give that there. There's a 30 to 35% chance of negative, meaning a normal laparoscopy. Laparoscopies do not reveal what is the cause of pain in up to 30% of cases, which means that these patients are then called normal. And the implicit assumption then is that the woman is making up the pain, or it's stress or anxiety. And this comes from a fundamental misunderstanding of the causes of pain, of not appreciating that there are now multiple complex inputs to what forms and emerges as pain as a phenomenon. And I think until we recognize that we have been misdiagnosing and mismanaging and delaying the diagnosis because we do not understand pain, we look at it from a fixed biomedical lens, that is going to be the first of the reasons why pain often gets misdiagnosed. Secondly, there's a systemic, we've talked about in AI this morning and yesterday, the algorithmic bias, the design in research, how historically research has always excluded women, has meant that all the findings and the systems are geared to somehow thinking that whatever is commonly seen in men, which is the focus of research from the 60s to the 90s, is applicable to women. But we now understand that the neuroimmune endocrine system in women is very different. The biology is entirely different. Adversity and the reaction of the nervous and immune system to adversity is very different. Trauma, medical trauma, sexual trauma is much more common in women. And we do not appreciate all of this. We do not recognize the impact of all of this in the nervous and immune and the endocrine systems when we make decisions about women there. And it's therefore no surprise that things get delayed, symptoms do not get understood, and what is essentially a complex multi-system phenomenon tries to get simplified into something that should be resolved with a pill or a surgery every time. There's a pill for every ill, and there's a knife for every kind of pain. And I think that is something we need to move away from, knowing what we now know about the neuroscience of pain, about how it impacts. And that leads on to the frameworks. And I'll broadly say that the 3 frameworks that we need to now be viewing women's pain so that we can make a systemic difference to the whole thing is, first of all, what I would say the why. Why are we doing this? And I think that begins by the approach of a trauma-informed approach of listening, validating. Healing can start only when there's first the response of safety and being heard. And I think that is the first part there, is the attention to social determinants of health, the understanding and awareness that there are other things impacting it. The second is going to be what we are going to do. And this is where my understanding and appreciation of the lifestyle pillars, has sponsored by so many lifestyle medicine societies globally, about the 6 pillars that come through, about the role of nutrition, about the role of connection, about the role of mind-body techniques, about sleep, about physical activity. How do we bring them together to create a curated, personalized, woman-centered plan? But the third part is most important, is how do you implement this? How do you bring coaching? How do you bring behavior change? How do you meet the patient where they are? And how do you talk to the woman on what matters to them rather than thinking what's the matter with them? And I think if we can bring these 3 frameworks together, that is where we are going to get the change. And I think if we can leave a woman, as you said so rightly, Shania, feeling believed, feeling safe, and feeling heard, then I think that's where healing can happen. And really, that would be the three frameworks we need to bring in, and that would lead on to probably the education that's most important. In some ways, I'd probably want to, at this point, you're practicing this. You're someone with lived experience. And I think that's something so important, that when we want to think about making change in the system, we are not supposed to be thinking of some kind of innovation wherein we do something for women, but I think it's important about how we do it with them. It should be a product of co-production and co-creation. So in that spirit there, you work closely with lots of women navigating infertility, a really emotional, personal, and again, a very misunderstood problem, really. From your holistic lens, the way you approach this, what are some of the subtle ways that you've seen in fertility care about dismissal, about being misdiagnosed or delayed? And how does your approach offer that agency and hope?
Thank you for that question. I often see women that if they have period pain, then they get offered the pill. And if they want a baby, you get offered IVF. It sounds simple, but in reality, this algorithm doesn't work. I've recently just had a lady who medically was told that she will never be a mother. Her AMH levels are 0.0. She's just told me 3 days ago that she's pregnant with her second child, using my framework, which is called the 3 B's for a baby. So I'm looking at the brain, following a logical plan. And then I help the body with my physical treatments, using acupuncture, using cupping, using traditional Chinese medicine, as well as Ayurvedic, and as well as Islamic Tib medicine. I'm integrating everything that I can to help this woman. But then I'm also looking at the belief, because women, as women, we hold beliefs, we hold unworthiness, we have the fear. We also have the hurt of what's happened to us. And then we have to navigate the uncertainty. Is this really going to be a solution for me? Can this really help me achieve what I want to achieve? And this is why I like to integrate all of these systems together, because it's truly a mind, a body, and a heart. And obviously, our heart in Chinese medicine, the second heart is your womb. Your womb is, and every single person in this room has come out of a womb. Thank you very much today for listening to us. And I'd like to open the floor for any questions, please. Be nice to us.
I appreciate. I'm not sure if this is on. Okay, perfect. I appreciate everything you were talking about in terms of women's health, and I'm curious, what's a better way to understand and make sure that this gaslighting stops fully and completely so we can support them?
Could you repeat the last part of the question?
What can we do as health professionals to stop the gaslighting of women once and for all?
See, medical gaslighting can be prevented once we start listening to the patients. The most important thing always in women is they can't come out at a time. So you have to spend some time with the woman to try to learn her root causes, and you keep on talking to them. They will open up and they will tell what are their problems, not only physically, emotionally. Sometimes they have a stress not only at the workplace, they have a stress at the home also. So keep on talking to them. You will come to a conclusion, yes, she is suffering with this, so we can help with that. Without listening and without talking to them properly, we need to spend time with the woman. If we start spending time with the woman, we can heal them. Once if you want to stop the gaslighting, start listening to the woman.
And also, this conversation, we have had experts, AI experts, we've got medical experts, we have the elite of healthcare system, and we are having these conversations. So invite us to the table, because we have a voice and we would like to be heard by the right ears as well. And this will also help to end the gaslighting.
Okay.
Eloquently said.
So my question links to the previous panel discussion as well. As we integrate AI into women's healthcare, how do we prevent the same biases towards pain being dismissed in women and from built into technology?
I'll probably take that one there in some sense, because right now some of my work is involved in looking at the challenges of AI and working with some companies in the UK leading on this stuff there. And I think the biggest problem is algorithmic bias and lack of transparency in the existing data sets that are there. A lot of the language models that are present right now still have largely Caucasian and Western data sets, with then the belief systems also that are inherent in those data sets, and the research that I talked about, which is also very much from the 60s to 90s, which have been focused on men as subjects there. I think until we start to get inclusive data sets, so the focus, the investment in research, the increase in understanding of the neuroscience of pain has to translate now into improving the quality of the data that's collected, ensure that there is inclusivity and diversity in the type of data that's collected, accounting for not just where a woman is coming from, but from the age, from ethnicity, from the hormone cycle, from across the there. And if we can get that kind of good quality data set that is built up prospectively, then that would be a true language model that you can then have some confidence and transparency should be ensured. So I think until then, trying to use an AI model to decide on how to diagnose or screen without a human being present there would not be advisable as the data stands now.
And as a follow-up, do you think we have enough data? Do we need more clinical trials in that sense?
Yes, so there's a very interesting book that there's this, have you heard Unwell Woman by Eileen Clegon? I would encourage you to have a read of that book there. I think we do not have good enough quality data set to make really well-informed, accurate decisions as it stands. It is reasonable to start looking at patterns, but it's certainly not enough to actually say we can feel confident in the output that comes from there.
And feed models as well. Yeah, great, thank you.
All right.
I have a question for Shanila. You mentioned that in Chinese medicine, the womb is like the second heart, and maybe a two-part question depending on how you would like to answer. Maybe explain that more in detail, or also give some more 2 or 3 concepts that are similar to that you think are important in women's health.
Thank you for asking the question. It's one of my favorite topics. The womb, so in Chinese medicine, you always have a brain and heart connection. But because the womb is actually the organ that is actually going to carry life, that is also intrinsically connected to a woman. So when we have the saying that my gut is hurting, or it's, I know it from my gut, because you also have the connection of your stomach as well with the gut. But what's happening here is the woman has an extra resource, which is her womb. So if she is feeling anxiety in her heart, it might translate into period pains, or it might translate into something wrong also in the womb area. Even the wombs are holding emotions. The wombs are also holding hurts, even with the inner child work, even with the inherited trauma. So there are so many things that are actually integrated into the womb. The womb is essentially her own body. And as a Muslim, we believe that Allah, the higher power, he created all of us equally, and we all bear witness that he is the only one to be worshipped. And at that time, the womb spoke. The womb said, "What about me?" None of the other organs spoke on that day, but the womb spoke, because the womb is so sacred. And then Allah said that I will honor the ties of the womb, because the ties of the womb is your family, is your mother, is your father, is your siblings. How are you tied to these people? Your grandparents. You are tied by the generations of wombs. And so this is very, very intrinsic. And I've also seen that as the mindset has improved, I've found that the womb releases, and there's always been some phenomenal detoxes as well.
Thank you.
Thank you for asking that question.
Awesome conversation. I just wanted to learn this. We all talked about this aspect about mindset, and they say that on a healthy mind, you can't have a diseased body. And as Dr. Vindhya very nicely said, and Dr. Deepak, they are all from India, I wanted to learn as to how important is meditation for us to improve our inner immunity system, for us to become well. Because I, for one, believe that we are over-drugged today, thanks to the pharmaceutical promotion. But I want the panel's opinion as to how important it is for us to believe and have this conviction that our human body has all the powers to heal itself. And maybe this as Dr. Vidya Reddy said, non-surgical or even non-medicinal thing should be more advocated, or should be more popularized. Your comments?
In this lifestyle today, so it's working. Yes. Okay. In this lifestyle today, where we are facing a lot of challenges with the stress and sedentary lifestyle, yeah, meditation plays a real role for controlling the stress. Especially in the women, stress plays a definite role in hormonal imbalances. So when there's a hormonal imbalance, your body will not be good. Women need hormones for her to stay healthy, whether physically and emotionally and mentally. So we always advocate, as I said in my 360-degree approach, I always have this part of mental capabilities and mental stability. So I always advocate them to do meditation. See, in this era of 5Gs and cell phones, for them to concentrate, to keep eyes closed for 5 minutes is becoming very difficult. So we always ask them to sit. So we encourage them. I have my own center. We ask them to sit and keep closed your eyes for 5 minutes daily. Then slowly increase your things. Then the stress level will come down, and their hormones also start going into a good conditions where their health becomes normal. So there are not two different things. Mental should be fine with all the well-being, with no stress and all those things, along with the physical. If both the things are fine, then the woman will be very good and healthy.
So, thank you for that question there. So, I wrote a book about sort of the neuroscience of pain as we understand now, called the pain-free mindset. Now, the mindset in that itself was an acronym. While medications and interventions were sort of acceptable, I talked about the neuroscience, the diet, stress, sleep, exercise and physical activity, and therapies of mind and body. So it is about bringing that whole thing together and having a different approach to it. And in mind-body techniques, when I looked at the evidence right now for what we look at meditation and mindfulness, what are the evidence for it? It's one of the strongest evidence base for using this in pain management, specifically in women's pain as well, definitely. Because as Vindhya said, stress is a big contributor. But we are also understanding that now that when trauma, when a variety of impacts occur on a developing nervous and immune system through life and the endocrine system, especially around the perimenopausal and these times, there is significant impact. And calming the nervous and immune system using non-drug approaches with meditation or mindfulness is even enough evidence base in that. Now, mindfulness-based stress reduction, I think everybody is aware of MBSR as a technique. But now there are more advanced trauma-based approaches, taking into account things like EMDR, DBT, internal family systems techniques, emotional awareness and processing therapy, pain reprocessing. So there are now enough evidence-based techniques to say that meditation and its more Western equivalents such as mindfulness, and in fact, mindfulness, when Vindhya talks about mindfulness doesn't have to be, or meditation doesn't have to be just sitting in one place counting beads. We are now talking about mindful eating, mindful movement, mindful chewing. Can you do one activity with certain consistency and flow so that your brain neural circuits just come out from their default setup into a flow? We talked about flow yesterday's panel as well. And I think we can achieve that with techniques like this, and I definitely agree. Those must be now our first options, or at least our foundational options, on which we can then layer in at the right time, at the right place, for the right patient, other standardized traditional approaches.
Thank you, Dr. Deepak.
This is the last question.
Okay. Hello. Thank you so far for all of your insights. I've really been enjoying listening to all of you. My question is, my friends, I see like a lot of women around me, my friends and family, struggling with infertility, and it seems to be something that is more common than not now. And I'm wondering, what are the biggest causes of infertility? One of the ones I've noticed is cortisol levels, feeling stressed. Is there something around that? And is there anything else that's causing more and more women to struggle in this area?
Shall I go? Okay. Thank you for your question. And that is true, because when cortisol levels rise, then hormonally your estrogen levels rise. And when estrogen levels rise, in order for ovulation to take, your LH, luteinizing hormone, has to overcome your estrogen levels. So if your estrogen levels are naturally high, the LH levels have to work harder in order to achieve ovulation. So that's a direct answer, or a direct correlation to stress and infertility. And then we also have to take into account that we have very stressful lifestyle. We have our eating habits are not the best. And we have lots and lots of people that are basically also, they are planning for children later in life. So that's also a factor in infertility. But it is really important to help with your stress levels. And this is also what I actually, I address this in my fertility program as well.
Causes. Hello. I just want to add one point to her. Stress even reduces your egg qualities. Once the quality of the egg, not only egg quality, it reduces the sperm qualities also. So if the egg quality is low, the infertility rate will be very high. As she spoke initially about the AMH levels, yes, AMH level shows us how many quantity of the eggs we have, but it does not tell you about the quality of the eggs. So quantity does not be equal to the quality of the egg. So the stress plays a major role in the quality of the egg, and the quantity also reduces very fastly. As a woman, we have at the birth around 40,000 eggs, but year by year it reduces fastly. But if you are very stressful, the loss of the egg will be very, very fast. So it goes in a very rapid action that even reduces the quality of the egg. That is the reason nowadays we are seeing many infertility because of the lifestyle stress which we are facing. The egg quality and quantity are reducing, but the quality is the most thing which is get affected. If your AMH is low also, if your lifestyle changes happen, you are healthy, you are stress free, yeah, there is a chance of you becoming mother. As she said previously, the patient has conceived on her own with AMH low because she has improved herself the egg quality. That is the most important thing.
I have a question that is at the intersection of opioids and pain. So we know that opioids are one of the most effective ways to treat pain post-surgical. And in fact, in some people, that leads to a severe form of addiction and ultimately the opioid crisis that we have all seen. So my question relates to how this differs between men and women at different stages in their life, particularly when hormonal changes in women occur, in different aspects of their life as estrogen levels change. I don't know much about that. If any of you could explain that, would be lovely.
Shall I go? Yeah. So yeah, and thank you for that question there. So opioids in general are at a dosage dependent reduction in hormone output, and especially hypothalamic and pituitary level suppression is a major factor. HPA axis suppression is a major biological factor as you increase your opioid dosage. Now, two parts to your question there. One, of course, in acute pain, nobody denies that opioids are fantastic, but in chronic pain, or when there is chronicity beyond 3 to 6 months, we do not have any good quality studies at all that suggest that opioids are useful for the large parts of the population in the longer term, which is why they've fallen out of favor, which is why the evidence has come out from the US and from Western Europe that actually opioids cause more harm. And indeed now, even in post-surgery in the United Kingdom, we've issued a recommendation from the MHRA, which is our regulatory agency, saying that even post-surgical long-acting opioids must not be given at the time of discharge from hospital for patients having undergone surgery there as well. We've realized that long-acting opioids are most addictive and most problematic. The real problem comes with the second part of the question that you asked is how is hormonal change occurred?
Yeah.
Now that is something that as far as the research goes, again, due to the fact that traditional opioid models and research in animals have been done on male animal models during the 70s to 80s. So the research that we have on how it changes has not really taken into account menstrual cycle changes, period changes, and menopausal variations. So what I've given you is a high-level overview that increasing doses of opioids suppress the HPA axis, causing a global reduction in all hormones. So as women come into the perimenopause, where there is unpredictability and instability in estrogen and progesterone levels and testosterone levels, this is going to cause a unpredictable change in their nociceptive apparatus. Estrogen especially has got a pro-nociceptive tendency, meaning that perimenopausally as well as postmenopausally, women are more prone to experiencing pain that is driven by a hormone sensitizing and upregulating a number of receptors throughout the entire nervous system. And these changes and upregulation in those receptors are not opioid sensitive at all. They do not respond well to opioids. And in those patients, we have to be quite careful. So this kind of pain is called central sensitization or nociplastic pain, and opioids are definitely not recommended for this kind of pain. The most common examples you would see of this pain are those that are seen in fibromyalgia, 80 to 90% of endometriosis patients have got that kind of change in nociplastic, and all the pain that you see with long COVID, chronic fatigue, Ehlers-Danlos, all of these are women-centered problems.
That was such a great answer because we are addressing women's health. I speak at 1:30, but we're using human models, not mice, as you were talking about. And so it is beautiful guidance for how we will do our science using your clinical experience and many of the things you stated. Thank you.
Thank you so much, everyone, and a great panel of discussion. Sorry, sir, you can meet them after the panel is over around. They'll be available for any questions. Sorry, before you go, I have a small question for this. This was a very interesting panel for me as well. I just want to understand when we talk about stress, so wasn't stress back in the day when our mothers were conceiving, and they went through much more stress than us, I feel. So why we talk about miscarriages now, why we talk about IVFs now? Just one question. I was very curious throughout the session. Yes. Okay. So I'm gonna spot all three of you outside, and I'm gonna I need this answer, that why we talk about stress and why we talk about therapies right now, but not before.
Yeah, I had a talk, and my opening line was that our grandmothers were more fertile in their 40s and 50s than we are in our 20s and 30s. And the reason why is because our mothers, they might have had stress, but they also didn't have this
phones.
They didn't have this pressure of outside models, of keeping up with the Joneses, of having the perfect Instagram picture.
That's right.
And also, as women, we were just meant to get married and
That's
have
right.
children.
That's right.
But now we want careers. We want to be business ladies. We don't want to just be tied to the kitchen sink, which I think is a good thing. But then we also, there's
Want
always
to do more than that.
Yeah, there's always a price to pay, because we do need to nurture ourselves and go into our feminine energy and not stay in our masculine energy state. A very quick answer, that is.
Thank you so much. Everything comes with a cost. That's what you said. Right. Thank you so much. Thank you so much. A round of applause for a great panel once again. I request you to please stay back for a picture.